Good morning, everyone, and thank you for joining us so early. My name is Stephanie, and this is my co-chair, Martine, and we would like to welcome you to Unraveling the Mysteries, Solving Difficult Pharmacotherapy Cases. So our objectives today is we're going to be looking at discussing difficult real-world patient case scenarios focused on pharmacotherapy and the management of cystic fibrosis, comparing ethical insurance concerns along with medication access issues, and then examining drug interactions and related side effects with all treatments in a modulator era. So thank you so much. And then Martine will introduce our speakers.
Good morning. Our first speaker today is Lauren Kormelink, who is a board-certified ambulatory care pharmacist at the Adult CF Clinic at the University of Kentucky Healthcare in Lexington, Kentucky. In addition to clinical responsibilities, she's an assistant adjunct professor at the University of Kentucky College of Pharmacy, where she teaches in the pulmonary therapeutics class. She's a member of the CFF Compass Advisory Board, a member of the University of Kentucky DG22 Ambulatory Care Pharmacy Residency Advisory Council, and a steering committee member for the University of Kentucky Adult CF Clinic Patient and Family Advisory Board. Please help me in welcoming Lauren.
Thanks everyone for being here on the last day, early in the morning. I think we have some great patient cases to tie together a lot of the things we've heard across conference. So I'm really excited to present my patient case, but also to hear what you all have to say about similar experiences with patients at your centers. So today we'll talk about navigating the unknown, novel approaches to care in a challenging patient case. I have no relationships to disclose related to this presentation. And we'll start out today I'll introduce the patient case that inspired this presentation, and then we'll talk through some novel treatments, some possible approaches that we've used or that we could consider. And then the focus today will be on our experience with my patient with bacteriophage therapy. To introduce our patient, she is a 22-year-old female, and she is a homozygote for Delta F508. She has several comorbidities, including chronic sinusitis with nasal polyps, seasonal allergies, pancreatic insufficiency with vitamin D deficiency. She suffers from gastroesophageal reflux disease, chronic constipation, restless leg syndrome, temporomandibular joint syndrome, as well as some mental health impact with diagnosed generalized anxiety disorder and a possibility but not a definitive diagnosis of bipolar I disorder. And she has also suffered with drug abuse in recent years. Her medication list is pretty typical of what you would expect for a person with cystic fibrosis. So she uses twice-a-day treatments with a bronchodilator, hypertonic saline, Dornase alpha, and then she is on inhaled fluticasone for a possible asthma overlap. She alternates chronically colistin and vancomycin nebulization for chronic suppression of Pseudomonas. And she is on triple therapy modulator, but of note, she has not been able to tolerate full dose. So she is one of our patients who has had some mental health side effects from trying to take full dose, and so we've dose adjusted her. And what she has done best with has been 2 tablets of the triple combination pills in the morning with nothing in the evening. So we tried several different approaches, and we tried tapering back up to full dose, but she feels the best when she's on just the 2 triple combination pills in the morning. So that's what we have stuck with for her. And she does take chronic azithromycin. For her sinusitis, she uses fluticasone, loratadine, and she is prescribed saline sinus rinses twice a day with budesonide. For her pancreatic insufficiency and vitamin deficiencies, she does typical PERT, as well as a CF multivitamin with high vitamin D and additional vitamin D supplementation. She takes a chronic PPI for her GERD, and for constipation, she uses some as-needed therapies. She's on magnesium for sleep and a little bit for restless leg syndrome. And then she is managed by a psychiatrist outside for her generalized anxiety disorder, for which she takes quetiapine, lamotrigine, and clonazepam. She is prescribed but non-adherent to buprenorphine naloxone therapy, so that has been a complicating factor in her care. We haven't been able to get her stabilized in a good program that can support her for being adherent to these treatments and being ready to work on that aspect of her care. And then she does also take a chronic probiotic, aspirin daily for prevention of clot with chronic port, melatonin for sleep, and methocarbamol as needed for muscle spasms, as well as her TMJ. This graph, if you're not familiar with it, this is from the CF SMART reports, and this is really helpful to see what's happening with a patient over time. So just to orient you to this graph, our x-axis is showing progressing time, with our y-axis showing lung function status by FEV1% predicted. The orange and blue bars that you see on the graph correlate to care episodes. So the blue bars are hospitalizations and the orange bars are home IV use. And so you can see that over the last 5 years, this patient has spent a significant amount of time utilizing IV therapies and being in the hospital. Some of these hospitalizations up to 45 days. And so this has had a huge impact on her quality of life. And this is breaking it down to 2 years, just to give you a better idea of her recent clinical status. She has spent almost as many days in the hospital as she has out of the hospital. So we've been pretty desperate to find something to help stabilize this patient, allow her to have more quality of life and stay out of the hospital. She's had this downward trend in her lung function ever since she turned about 16 or 17. And so we've been trying to find a way to prevent this continued progression. As far as her sputum cultures and susceptibilities, she does chronically grow Pseudomonas. More recently, back in about 2020, she started chronically isolating MRSA. So we did try an eradication protocol, which was not successful, and now she has chronically grown it ever since. It does appear that a lot of her clinical decline has occurred since this MRSA isolation, so that has been of importance to us, but she does still have this highly resistant Pseudomonas. So you can see this is a very busy slide. I know you probably can't even read all these words, but this is a patient-specific antibiogram that we're able to generate from Epic at our health system. All of the yellow or orange boxes show resistance for a pathogen to an antibiotic. So the point of me showing this to you is her Pseudomonas is highly resistant. So we've been very limited with all of these exacerbations with how to appropriately treat her. And we are essentially at this point limited to things that have complete resistance, trying to just find what we can use for her that will have enough clinical response. And I know our resistance patterns are kind of controversial. Do we listen to them or not? We try our best to consider them. If we have something that's susceptible, we may steer towards that. But we know some patients will improve even with an agent that is resistant. For our patient, it seems from course to course like she has different response to different antimicrobials. So it's been difficult for us to find the best regimen for her. And then I do have highlighted, she did isolate earlier this year Aspergillus and met criteria for ABPA treatment. And so that was a further complication on her course of care. As far as hospitalizations, looking at the past 2 years, in 2022, she had 7 hospitalizations and spent 150 days in the hospital. And this year, at the time of making this presentation, she had so far had 8 hospitalizations and 97 days in the hospital. So a huge impact on her life. Another complicating factor for this patient's care is that she has extensive allergies and intolerances that limit our ability to use different antimicrobials and different agents. So for this patient, we have pretty significant allergies that have been limiting for treating her exacerbations, specifically with targeting her Pseudomonas. And then we have seen this ceftaroline, which we're using for her MRSA, that she has issues with that as well. Some of these have been mild enough that we've been able to use them if we've needed to treat through, but some of them have been more severe allergies. And for intolerances, you can see the list here is pretty extensive as well, mostly antibiotics, but we also have our antifungal agents. So when we tried to treat her ABPA, we found that she was not able to really tolerate any of our antifungal agents, including isavuconazole. And so we have essentially just had to decide that we won't treat that for now, and hoping that we can find another way to stabilize her clinically. So you may have noticed several challenges in this patient. You may have seen some of these yourself, but we have a patient here with extensive allergies and intolerances. We have some barriers with tolerability to antifungals when we're trying to treat her aspergillus. We have barriers with optimizing chronic medications due to intolerances to certain inhaled antibiotics, as well as inability to tolerate full-dose CFTR modulator therapy. She is also experiencing multiple resistant pathogens that are chronically infecting the airway. And the impact of her mental health does have an impact on her adherence to therapies. So we are pretty sure she has suboptimal adherence to therapies, and that is a big factor in why. So we need to help her with navigating all of these issues, and we have sat down as a team and talked about and utilized a lot of novel approaches to her care. So some of the options that we have considered or have used have included antibiotic desensitization, which we've heard about in some previous sessions. Unfortunately, she is one of our only patients who has failed antibiotic desensitization, so we haven't been successful in that with her. We've tried utilizing some of our newer anti-pseudomonal IV antibiotics. We've attempted oral suppressive antibiotics for the MRSA since we saw that that clinical decline did seem to correlate with when she started chronically colonizing MRSA. However, she wasn't able to tolerate those oral suppressive antibiotics. We tried non-commercial inhaled antibiotics, including inhaled ceftazidime, which she wasn't able to tolerate. And so we got to this point that it seemed like our only option was trying to pursue phage therapy. So this is a patient that ties in perfectly to our plenary session that we heard yesterday. She seemed like the perfect candidate, and so the question was, what really is it? We've heard about it for years, but I didn't really know a lot of the details of how it worked or how to get it. And how to get it was the biggest one, right? We got to figure out the access component. So I learned a lot along the way, and hopefully I can share it with you all to help you if you have a similar patient. Just to quickly review, we'll go through pretty fast since this was in the plenary yesterday, but bacteriophage or phage therapy, it's a virus that can infect and replicate, but only in bacterial cells. So these phages can be specific to a certain type of bacteria, and what they do is attach to the host, inject their DNA into the bacterial cell, and kill the bacteria. They naturally occur in the environment in a very diverse range. So I was very surprised to learn that often these are isolated from runoff water or sewage wastewater, and that is where we get these from the environment. And so they are it's somewhat limited. Each certain phage has to be isolated from the environment, and they're working more on synthetic production in the lab for more consistency. But the history is that these do get isolated naturally from the environment. Some of the more pertinent bacterial targets that are being highly studied right now include Pseudomonas aeruginosa, Staphylococcus aureus, and non-tuberculous mycobacteria. And these can be administered both through intravenous route and nebulized. So here we have a picture of what a bacteriophage looks like. The DNA is housed in this capsid head, and then the bacteriophage has this long tail with spikes and tail fibers that help it attach to the bacterial cell to inject the DNA into the bacterial cell. We heard about one of the ongoing clinical trials yesterday, but there actually are two ongoing clinical trials with phage therapy. They are both in phase 2, and these are options for us to potentially pursue for patients. However, I will say that as with many of our clinical trials, the inclusion criteria requires for patients to be fairly stable, so not having medication changes for 30 days after enrollment. So for us, this has been a huge barrier for our patient because not only would she have to travel far away for trial, she would also have to stay clinically stable, which has not been consistent with her history. So that brings me to the Center for Innovative Phage Applications and Therapeutics, or IPATH. IPATH has been the pathway that I have utilized when we were attempting to get phage therapy for this patient. IPATH was founded in 2018 by the University of California, San Diego School of Medicine, and they had a goal to work with researchers and other institutions around the world to try to find new treatments to combat antimicrobial resistance. And the specific focus for the group is bacteriophage therapy. So they've become sort of a repository for coordinating care with bacteriophages. They have lists of all of the different labs that are completing research with phage therapy, and they're fairly easy to get a hold of. When I found them, I thought, man, I'm gonna have to email this general email. Who knows how long it will take to hear back. But Elizabeth Lampley, the program coordinator, is amazing. She usually responds same day. Very easy to work with. And the best way to get her is by email, ipath@health.ucsd.edu. So if you have a patient that you think you might need to get phage therapy for, I would take a picture of this slide, and I'll pause for a second so you can do that. But she is really easy to work with, and she essentially does all of the heavy lifting. So before I found iPath, I was Googling and reaching out to all of these random labs, trying to get people to email me back or to take a meeting with me. But Elizabeth has all of these connections with all of the programs, and so she's a very easy way to try to get connected with a lab. So the process for trying to obtain phage therapy starts with contacting IPATH. IPATH then will reach out to clinical trial sites or other research groups and then connect you, the clinical team, with the research team that's willing to accept the patient. The lab will test the patient's specific bacterial sample to try to find out if they have in their phage library a phage that will provide adequate killing of the bacterial cell. And then the next step is delivery of the phage to the patient. So it sounds really easy when I say it like that, but it's actually a lot more complicated than that. So when you contact Elizabeth at IPATH, you'll want to send her a little bit of information about you, your practice site, a general overview of your patient, de-identified obviously, but just kind of explaining what's the pathogen that you're worried about, what kind of resistance does the patient show in sputum cultures, lung function, clinical stability, exacerbation history. So just kind of a quick overview so that she can get an idea of what the best labs to reach out to are. Some of these labs specifically work with only one bacteria. So there are some labs that only work with NTM. So she will do the heavy lifting to find the lab that's the best fit to match you with. So she reaches out and does all that hard work. She reaches out to research labs, clinical trial sites, pharmaceutical companies, biopharmaceutics companies, industry, anyone she can that she thinks would be a good match for your patient. And then if someone responds to Elizabeth and says that they are willing to accept a meeting with you, the clinical team will meet with that group to talk about more of the patient case specifics, the pathogens, the specific treatment goals. And you can talk at that point about, maybe you're matched with a clinical trial and speaking with a research coordinator to find out if your patient will meet inclusion criteria. That is one barrier, is failure to meet inclusion criteria, because for us, this patient is not stable enough to participate in clinical trials. So that would have been the easiest avenue to get her phage therapy, but unfortunately it was not an option. So we did eventually get matched up with an industry company that was willing to discuss moving forward with compassionate use for this patient. The next step is testing the patient sample. So it sounds easy, but first of all, your patient has to be able to provide an expectorated sputum for some of the labs. This may require contracts. For us, it required a material transfer agreement through our lab, which was a major barrier as far as timing. It took a pretty good chunk of time to get the lab to agree to do this. And then even when you transfer the sample, you're not guaranteed that the phage is going to be available and to respond. So it's important to set expectations with your patient that, we don't know, we're still learning about this. And even if someone agrees to take on your case, it doesn't mean that you're going to end up getting the therapy. And then the last step, delivery of phage to the patient. This can be complicated because if you're looking at a clinical trial, the patient may have to travel far away to get there for several visits or possibly an extended stay. If you're looking at compassionate use, you're looking at having to get an FDA IND process in place, an IRB through your institution to do that, having your patient sign consent. So there's a lot that goes into this process. And for us, unfortunately, we have not been able to get phage delivered to the patient. The industry company had agreed to do compassionate use, and then when it got down to the contract, we were waiting on them to send us a final contract. they kind of fell off the radar. We reached back out to them about a month later, and they at that time told us that they no longer wanted to consider working with us. So we unfortunately, after over 18 months of going back and forth with that company, we're back to the beginning for our patient. So not the best end story for us, but I'm hoping that this can help others, that if you have a patient who is more stable, try to get them into the clinical trials. That's the way we're going to push this forward, is getting it studied. So if we can help to support our teams that are doing clinical research by sending our patients to those centers, we can maybe streamline getting this to our patients faster. Some of the results that have come out so far have looked really promising. So I'm hoping eventually we'll have this as an option for my patient, but right now we've kind of been stuck. So we're trying to do our best, and I know that that's all we can all do. Everybody sitting in this room has a patient that I'm sure has similar struggles. But if there's any way that I can help you with navigating phage therapy, I feel like I've learned a lot. I've gained a lot of contacts. We've worked with some of our non-CF patients that have difficult to treat Mycobacterium abscessus or Mycobacterium avium. So I'm happy to help collaborate, and probably could have spent the whole session just talking about this patient's care. But thank you for taking the time to listen today.
And we're now open for questions. Do we have any questions?
Thank you for that. Very, very cool. So if you've been able to participate with the industry, do you know if they were had a mechanism in place with the phage treater center, or was she need to travel somewhere?
Yeah, so the question is, if we would have gotten the compassionate use program in place, what would it have looked like for access to get the drug? What we had discussed was that we would likely administer the phage while the patient was inpatient so we could monitor, since there is so much unknown about it. And so they would ship the medication directly to our investigational drug services pharmacy, and then we would administer to the patient observed while she was inpatient, was what our plan was. And I should mention there are also concerns with how phage therapy can interact with different antibiotics. So one of the concerns that the lab had for us was we were going to treat with phage while we were also treating an exacerbation. There are different approaches. Some will treat while they're well without antibiotics. Some will give them while they're on antibiotics. And so our plan had been to treat her inpatient, so we were going to do it while she was on antibiotics, just so that we weren't having her come in for a hospitalization when she didn't need antibiotics, since she spent so many days in. But there is a chance that some of the phages can interfere with how well the antibiotics work. So the lab had to also specifically test the antimicrobials that we wanted to treat her exacerbation with, to make sure that there wouldn't be any negative interference. Has anyone here successfully gotten their patient on a phage therapy? So no one in this room. I know there's somebody somewhere, and I know these clinical trials are going on, but I've never.
One patient, but I can't take any credit for it. He sought out going to Georgia, the country.
Okay, wow. Okay, so one patient got it from going to another country to get it. Okay.
Yeah, he did it for both the Pseudomonas and MRSA, and it was the summer of 2019.
2019, okay.
He did great.
Mm-hmm.
And then started right after, so I don't know.
Yeah. Well, please feel free to email me if you think of any questions or want any help navigating this process. Elizabeth Lampley is amazing, though. She's so easy to work with, and I had been working on just trying to find a connection for probably 6 or 8 months before I found her. And then once I found her, I was like, oh man, I wish I would have Googled a little bit better and found her sooner, because she made it a lot easier to make the connections than it was just, working with the biotech company to try to get them to realize the importance of this. So thank you so much.
Thank you. Thanks, Lauren.
All right, our next speaker is Dr. Lisa Lubsch, and she is a clinical professor in the Department of Pharmacy Practice at the Southern Illinois University Edgeworthville School of Pharmacy, and clinical pharmacy specialist at SSM Health Cardinal Glennon Children's Hospital in St. Louis. She provides care to children with cystic fibrosis and other pulmonary problems. She's board certified in a pediatric pharmacy and a fellow in the Pediatric Pharmacy Association. Please welcome Lisa.
Thank you for having me. Yeah. Lauren, that was excellent. I like everybody else's bios that have like, I love dogs or whatever. So I'm going to add to mine. We've got my Bruno crew in the back there, some of my team. And I really appreciate you allowing me to have my son here with me. And hopefully he's not been too distracting for you. I'm going to take a little different approach in where we are going to stop at one time point for my patient during an acute exacerbation. Of course, you are going to get their history, but like Lauren had to set the stage of why we needed to go to phage therapy. Mine's a little different of we're coming to a perfect storm of all these different issues that we've actually already heard about, of course, at lots of different sessions here. So again, I'm also going to summarize some of the issues that we've encountered already the last couple days. Maybe. Okay, so we're going to talk a little bit about mental health again, but we're going to add another layer to it in terms of transgender care and cystic fibrosis. On top of that, complicated regimen with managing a bacterial infection with Mycobacterium avium complex. All right, so here's my patient, WM. Now, for those of you that are pre-modulator era like myself, I have known this patient, of course, since they were very little. And he was a frequent exacerbator, growing up to where I just recall young childhood of all the art that he would do in his room, in our relationship that we've established. And so hopefully this case is also a case for those that take care of children, but then have to transition them to the adult care, where that's where he's at right now. So he spent the last, 6 to 8 months over at the adult center. So that's a very hard thing for us pediatric folks to deal with. So this actually time point is not in my care anymore. So I had to get into the chart, that I hadn't seen in a while. So it was a good, reminiscent for me, but also, a transition period as well. All right, so 18-year-old who was admitted for an acute pulmonary exacerbation. The symptoms that he was having was a 5-pound weight loss just within the last week, more sputum, which was thicker, greener, with an increased cough, denied any fever, chills, or night sweat. Hasn't slept for 2 days, with the overwhelming feeling of depression and anxiety with no suicidal ideation. Here is the current spirometry comparing it to the last one that they had, which was 5 months prior. So looking at the percent predicted of FEV1, going straight to that was 59% predicted, where I have in liters where he was at the initiation of Trikafta. So here it was 1.75, but when we had our Trikafta visit, it was at 3 liters. Good, all right. So that's our time point here, where the physician labeled this as a moderate to severe pulmonary exacerbation. In terms of what treatment ensued, he does have a history of Pseudomonas, MSSA, and previous steno that they chose not to cover so he got ceftaz and tobramycin this admission. His past medical history, he is homozygous for Delta F508, and it was diagnosed prior to newborn screening and all that jazz, but was diagnosed neonatally with amniocentesis. I don't know if anybody in the pack can tell me, I don't remember what our first visit was. This was pre-EMR, so when he was established at our center. Complicating the situation, NTM has been present for over a year now, so cultured it a year with us at the pediatric center, and we started, the triple therapy for the Mycobacterium avium intracellular. And we were able to get some negative cultures throughout that year, but this particular admission, it did grow. So fast forward a few days. We do have a female-to-male transgender patient, and we first learned about that at about 16 and a half years of age, where, he let our clinic know. And I also, need to tell you that I work at a freestanding Catholic institution, just to level that up. And, what kind of care we can provide there for folks going through gender incongruence. Does have a history of depression with suicidal ideation, not current though. Previous PHQ-9 score of 18 with the suicidal ideation, but no plan. Some backstory here, family member was killed earlier this year. He quit his job due to a discrimination issue, cannot find current work. Partner breakup that was recent. Was trying to become an EMT and failed that exam. There's food insecurity currently, and we'll talk a little bit about the testosterone potential impact with the depression. Does have also a history of anxiety, of course, pancreatic insufficiency, CFRD that's currently diet controlled, used to be on insulin with us. I did want to back up and talk about the gender incongruence, that the parents are supportive. However, everyone in the home wanted to wait for masculinizing therapy until 18. So this patient had been on testosterone for a few months, but we were unable to provide that at our center and at the center that he transitioned to, and so advised to go to a different center, and of course, Planned Parenthood has options for care. All right, so med list, because we can't be at a pharmacy talk without this. So yes, on ETI, you'll see full dose, and there is our mycobacterium regimen, started 12 months prior. Nothing else unique really there. Fluoxetine is a long-standing med. And then below, started testosterone 8 months prior to this particular visit. Took it for about 4 months and then, in quotes, ran out in the chart. Really there was, he preferred to stop because of the injections, wasn't able to really get needles or access to needles well enough. What was reported, I wish I would have been involved. I would have, helped take care of that. But again, outside of our care at that point. And then in this particular admission, I looked back and that at his very last visit, testosterone gel was prescribed at the endocrine visit, but was denied and it was in an appeal, and no one had taken it a step further for him. All right, so we're gonna go now and talk about transgender care and what we know in specific to CF transgender care. I only found one article so far. So there's a lot that we can do to grow this literature. So there was a survey completed of all centers and only 30 replied. So this is a survey result of 30 centers. And there were duplicate encounters that were patient, encounters that were given to this survey. So there are more patients than the 30 patients. I say 30 surveys at 18 centers. I take that back. So only 18 centers out of the entire accredited centers replied, but we got 30 surveys back. So this is of 30 people. And it was a pretty even distribution of gender here, where there was 36% male to female and 43% female to male. That the average, or the span of the age was 7 to 35 years of age. So, it can be touched at our pediatric and adult centers. The majority of folks were undergoing medical transition. It was more common in trans men to go through medical transition, and that's defined under the chart here. It typically involves the use of hormones or surgery to affirm one's gender. And then a subset of patients were only doing social transition, which again is defined, where it just involves making changes in relation to interaction with others to align with one's gender expression. I think the other things that you can see on this table is we'll look at FEV1 and BMI better on the next slide. But were they able to have resources within their center? And there was a discrepancy here where more services were available to trans men than to trans women at their center. So an overwhelming majority of trans men were able to get care where they were located, but trans women were not. All right, so to just take a peek at what the medical transition looked like, the most common therapies for masculinization were the use of chest binders and testosterone, followed by surgery. In terms of feminizing therapy, of course, estrogens were the most common. And if you see the breakdown during transition, was there a change in FEV1 and BMI? No, there was no statistical change in FEV1 or BMI. Okay, so this was really it in the literature that I could find, unless somebody has anything else to share with us specific to CF. But I did find a really nice review article that really can talk about all the different things to think about as we care for gender diverse people. And I will tell you, our listserv has also been amazing. So this isn't the only patient that I have in my center where when I encountered the 2 patients, I reached out to you all, and there was an overwhelming response. I had like 3 people who threw out the guidelines that are current to me. We chatted online about issues related, to feminizing therapy or masculinization therapy. And so it was very helpful to use each other. But this paper was helpful too. So the first particular statistic is in general, not specific to CF. So 1.6 of all Americans and 5% of young adults identify as transgender or non-binary. This was a 2002 survey. And again, there's no prevalence data in people with CF, but it's estimated based on those numbers that 200 to 300 people with CF are gender diverse, okay? That then the next particular point to think about is we will have an expanded role for endocrinology, so they will take care outside of CFRD here if they get involved at your center with transgender care. Of course, there's going to be an increased rates of depression and anxiety, which really hits home. My patient, disordered eating is talked about within this article. In terms of chest binding and how it can impact pulmonary function, there isn't a study specific to CF, but there is a non-CF study that did result in a reduced FVC that we need to consider. And then how surgery could influence pulmonary function is still represented in the literature. We could spend some time on hormone therapy and its impact in CF, lots to be learned there. In general, though, how hormone therapy could impact is that, your gonadotropin-releasing hormone analogs may reduce bone density. For transgender women, they're at an increased risk of pulmonary exacerbation and cerebrovascular disease, and that's why estrogen patches may be preferred in that particular, to decrease that particular risk. For transgender men, polycythemia needs to be watched, specific to increased hematocrit, and then increase in triglycerides and pelvic pain. So these are the side effects beyond mental health and well-being that need to be counseled about. But the only thing that you can find specific to CF in terms of hormone therapy and impacting CF is what we learned yesterday again at the plenary was estrogen may increase Pseudomonas infection, worsen lung function, and increase acute exacerbation, pulmonary exacerbation. Beyond that, we still, again, have so much work to do. And then finally, the biggest thing is, what is our ETI effects or ivacaftor effects on hormones specifically? And I could find nothing yet in the literature to describe anything of what we should worry about with ETI and ivacaftor. I did want to pause there if anybody has experience, because we are going to switch gears here in a minute to talk about mental health. But if you have a patient that you want to talk about real quick where you've started therapies and saw this side effect or had to, change therapies, I open the floor for a minute. I can't be the only one encountering transgender care, so please speak up.
As for a positive side effect, in N of 1, we had a young trans guy go on hormone pre-ETI and had a bump in body mass index and a corresponding bump in
FEV1, that's fantastic. Yeah, makes sense. Thank you. Any others? All right, well, it's coming. So to conclude on transgender care, I did want to throw out the caveat that, of course, we encountered specifically. So that clinic that he was utilizing also had to shut down recently, and the only option left then is Planned Parenthood or going to a neighboring state to Missouri. So I'm in Missouri. And so it's made it even further complicated of providing care for transgender individuals. And so you probably have maybe been touched by this depending on if you're in a red state or not. So hopefully, we can figure out how to provide the best care, for patients that are walking this journey. All right, just to pivot just a little bit. And so I found this quote on the foundation's website from, they have these stories that they put out there for patients. And how could something that makes me feel so great physically make me feel so crappy mentally is a quote directly from her story, that Lauren's story on the CF Foundation's website. And so what she's describing is starting ETI. And Michelle Condren's physician in our session yesterday, she read my mind, but took it even better, where they gave us a nice presentation. And so I encourage you to go look at that abstract if you want more information and weren't there yesterday, on looking at the FDA adverse event reporting system for ETI psychiatric side effects, because none are listed right in the package insert. So we've talked about this a lot the last 3 days. So the only thing that's, neurologic in the package insert is headache. So where do we go? We go to the post-marketing data, and this is what we get. So I did not filter it out as eloquently as that physician did and presented to us yesterday. And so what you're seeing here then is the top 3, which is very consistent with what she presented yesterday, is anxiety, depression, and insomnia are the most heavily reported adverse effects to the post-marketing data. She specifically pulled out anxiety, insomnia as the top 2 in 12 and above when she really filtered out the data. So I will recall that from you from yesterday. You can spin this data by age. And so there are, if you go to look at the updated reports, because she didn't have the under 11 or under 12-year-old data, she stopped it at the 12 and above, that there are 65 reports in the 3 to 11 age group of some varying side effect. And then you can also see here the different outcomes by year that are published on that website, that there are some outcomes that were considered hospitalized or life-threatening or serious. And so I do think that, given like the European warning is coming, correct? And this just definitely warrants a more systemic evaluation. And I have not heard whether there's something that's going to come for us that isn't post-marketing data and, more prospective. Is it coming? I mean, we have to do this, so there's just a call to action. Because here is all the other data that has been published. And so, again, we've seen a lot of these trials already talked about in our sessions. I had to hurry up and go to the speaker ready room to add the final one, because you guys had that one on your slides, and I'm like, well, I need a complete slide. So I'm gonna go hurry up and add that one, because I missed the most recent one in July. But backing it up, I did go further back in the literature. And this is just specifically to ETI. I didn't look at other modulator therapies. So there are other case reports out there for ETI that are not included on this slide deck. And then, of course, there's other literature out there for the other modulators. I think in general that there's conflicting evidence as you look at this slide in terms of some studies show that there's no change in PHQ-9 scores and anxiety scores. And there are some improvements in some trials, and there are some who have a decrease in their scores. And so it's variable, what happened when people started ETI. And I think that there's another 2 abstracts here at this meeting that specifically looked at change in depression and anxiety scores. So please look at those as well. I did not add them to this slide. And then the other things that you see here are what are the symptoms that folks are having. And so folks are really expressing a mental fogness, seems to be, or, a neurocognition issue, more so than mood changes and anxiety. Probably to almost an equal level is making sure that you describe this brain fog that a lot of these trials have talked about. Now, I think the other thing to take home is, are we dose reducing, and how are we dose reducing? And so dose reduction did work for a majority of patients throughout these case series. And they are of the variety, as you've seen these awesome, orange tablet and blue tablet slides that people have put together. I didn't put together one for you. Of majority, I think people would say, though, that they are reducing to 2 orange tablets. But again, a lot of different variations in the dose reductions and how it will work. And, Nicole mentioned yesterday that why is this happening? And so if you weren't at Nicole's session yesterday, I'll just allude that is there an interaction with your antidepressants or anti-anxiety meds? Perhaps, but not everybody's on medications who is experiencing these side effects. So we do know that there is CFTR expression in the brain and the spinal cord, and that maybe there is some activity there. Ivacaftor may have activity at a specific serotonin receptor, so whether that's impacting. And so further, again, research needs to be done to evaluate the specific impact on CFTR modulators on the CNS. All right, hopefully I summarized all that pretty well. We're gonna pivot completely now into looking at this patient's NTM infection. So of course we will start with the recommendations, the consensus recommendations from European and North American guidelines, and what our typical regimen is: azithromycin, rifampin, and ethambutol. And Sarah, I don't know if she's here, she also did a very eloquent job. Was that yesterday already? Oh, I think exactly the same time, describing what we did, which was rifabutin. So the reason why, we got this idea on our listserv is that rifabutin is structurally similar, like rifampin, but it is more lipid soluble. So it has a larger volume of distribution, a slower clearance, and yes, it may have more adverse effects, but it may have then a much lower impact on our drug-to-drug interaction. So we all know that ETI are all substrates of cytochrome P450, 3A4, to where we have this, of course, we avoid use with rifampin, but let's consider use with rifabutin. And so we did in our particular case, and we're going to talk a little bit about, should we monitor concentrations or should we look at sweats? Should we do both? But prior to having that discussion, I did want to talk about the one CF study that looked at pharmacokinetics with use of the traditional triple therapy. And so I'm not going to claim to really explain this picture very eloquently. But what we have here in the gray bars is 2 standard deviations below and above of what concentrations we want to be at, or what I guess is considered normal. So in this particular study, they did a single dose pharmacokinetic analysis and 10 controls and found your gray bars. And then they did 20 people with CF, and that's the lines that you're following. And so they either did it in a fasting state or in a fed state, and found their concentrations for all 3 drugs. Really, the take-home message here is that it's 19 of the 20 subjects had 1 or more abnormal Cmax Z-score outside of that gray bar, or outside of what those 20 controls represented. So nearly all CF subjects had at least 1 peak drug level outside of what is considered the normal range. So our standard dosing guidelines may not be it. We should be using them as the conclusion from these authors is that we may be using these dosing recommendations as a starting point for people with CF and initiating MAC therapy, but we should probably be doing therapeutic drug monitoring to make sure that we are achieving what the recommended concentrations are. So here those are. So I had to find them a little bit. They're not wide out there in our literature, so this is a helpful table for me. But what do those guidelines recommend? So the CF Foundation and the ECFS say we don't routinely get concentrations. However, I love the bolded part. For those on concomitant medications with significant interactions, we should consider getting therapeutic drug monitoring. So even, these were written back in 2016 before we were really thinking about ETI, right? So I'm so glad, that there is a caveat in here that says, let's do it. So I would like to see by a show of hands. I am not one that has done it yet. This isn't my patient anymore, but I want to do it, right? So, but how many of you are routinely in your drug-to-drug interaction patients getting concentrations? All right, so there's a show of hands, because yesterday, I don't know that we asked that, but it definitely is something to institute. Are you doing concentrations then outside of the drug interaction? How many people are getting routine concentrations just to get them? All right, so we have a lower amount there. What I found, and correct me if I'm wrong, those of you that are clinically doing this, since I haven't got to do it yet, is that it's a peak drug concentration 2 to 3 hours after administration. Is that holding true? Are you doing troughs?
We're doing 2 to 3 hours.
Awesome. Okay, awesome. All right, and for us, it would be a send-out laboratory. Is it a send-out lab or is it in-house, or are you Colorado?
Abe is the PA.
Oh, nice, you could have been answered. Oh, nice. Well, thanks for speaking up. She could have been speaking up the whole time. No.
We send it out to Florida.
Yeah, to Florida, okay. All right. Any other questions or comments about therapeutic drug monitoring? Yes? So those that have done it, the question is how complicated, is it how complicated? I missed your adjective. Oh, how expensive? Oh.
It's free, isn't it? Right?
It's covered? I mean, you just went with it and,
I'm not sure.
yeah.
There's still weird billing, you guys. The order form is impossible to find, but there's a little number at the bottom, and the lady picks up the phone, she's great. You can't send it on a Friday. I mean, it's one of these things, and you have to put in like this billing for your hospital lab, and it gets billed to the hospital, and I don't think it's ever hit a patient's, okay, I'm good, yeah. They don't get charged.
That's great. Yep. Yep. Awesome. All right. So I do want to end with a discussion on sweat chloride, which I think it would be a great discussion if we have more time for. So is this a biomarker for CFTR activity? It's not the best one, right? We've heard that at multiple sessions this meeting, that is it a surrogate for clinical efficacy? Doesn't greatly correlate with lung disease severity and FEV1. There's so much individual variability. We do have non-responders, so it's just not perfect, right? But it does have a role. And we are doing sweat chlorides in our clinic for certain reasons. And so this particular patient, we did do a sweat chloride. So his sweat chloride on ETI and rifabutin was 95 and 95. Now, I did my due diligence and went back and did our refill history and called him. I didn't, the nurse did. There was only one refill this year for ETI, so we didn't get a good capture on that sweat chloride. He said that he was busy because he did get a new job, and that he's working nights, and that he doesn't get his phone calls, and so his adherence is to where that this is not then going to show me whether or not the interaction is of an issue to clinical efficacy, because we need to take the drug to even, consider resweating. Another way to consider a sweat chloride is if you needed to do other dose adjustments for either an adverse effect or any kidney or hepatic issues. I think the biggest reason we're doing it is to justify changes in hemp therapy. So like if we wanted to show like moving from Kalydeco to ETI would be the right thing for a stable patient, this would be one way to obtain that sweat chloride and prove whether or not it would be beneficial to move on. But yes, is it an adherence marker? There's a lot of practical issues that I can see this red button beeping at me that I need to stop talking. Anything else about sweat chloride that I missed? I'm sure there's several. So let's start with a show of hands, because I don't think we got that poll yesterday. How many are using sweat chloride for any of those reasons? Are you monitoring sweat chloride? It's becoming a commonality, just so you guys see that. All right. So back to the patient. Again, I already alluded, started working at a construction company, did establish care at a gender-affirming clinic, and is back on some testosterone, but does not have a therapist for that depression and anxiety, does desire surgery for transition, and, continued support with Planned Parenthood is what we are encouraging. All right, so any questions? Lots and lots of topics there, so lots to be talked about. Yep.
I just have a question about the sweat chloride. So I've wanted to do repeat sweat chlorides for many of the issues you've mentioned, and I've gotten pushback from patients billing. So our clinical coordinator states that we have difficult time getting it covered by insurance. So for those centers that are using it, how are you doing it? I'm not involved on that end, but
Yes.
I would love to hear good feedback on how you've gotten that to be
Judy,
successful.
can I call you out? Would you be willing to speak? So I have a table back there, and Judy takes care of this part. Yes. Sorry, Judy. Yeah, they'll hear you. Yeah. And while she's walking up, if anybody else wants to talk too.
So as Lisa mentioned, I'm Judy from Cardinal Glen, and we're a pediatric facility, and we've had a lot of difficulty, first of all, with sweat test and getting accurate rates because of our QNS issue. I will say, though, for the patients on highly effective modulator therapy, it's been less of an issue. I think in part because they're older, and we actually have parents that are amenable to us sweating their children again. Now, the adult population is different, right? It's time-consuming. It's a day from work that's missed, but we don't have any pushback, with the exception of maybe one patient that I'm thinking of, that we are questioning adherence. So it's not a big issue for us in the pediatric population. It is, I suspect, billed to insurance, though I have not been told if it's, if it's an issue.
Right. No one's come back to say that they're getting paid, they're getting billed for it specifically, carved out or anything. Yeah.
Right. And then part of the check there, the check study was helpful too, because when we started patients on the therapy and then within 90 days we'd repeat the sweat test, it did show that there was an effective change with the therapy, and then we also use it to go back to double check for adherence issues.
And it'll be part of the BEGIN study too, right? That's the name of the next trial, BEGIN. So you'll also have access to those sweats, which I think will be great.
Right, and the other, you have to have a lab that's on board with doing this because it is so technique dependent to do the sweat test. The recommendations are no more than 2 to 3 people that are doing sweat tests in the accredited centers. They are supposed to be checked within the first 6 months and then annually thereafter. And that's an issue with our lab for the support staff because it is very time consuming. To collect sweat for 30 minutes and the prep before and then making sure that they have enough volume. It's upwards of a 60-minute test that's pulling that phlebotomist, that's who does our sweat test, away from other patient encounters.
Yeah. Thank you, Judy. I
You're
called you
welcome.
out. You're going to kill me later, I know.
And I think we have time for one more question.
Okay, Lisa, great position on the ETI side effects. I did talk to Vertex before I left Utah.
Yeah.
And they said there's no information in their data lock.
Right.
The FDA said nothing.
Right.
And I said, you guys are lying. I did.
Oh,
And they said, no.
Sure.
No, they collect the information because Vertex GPS calls the patients
Sure.
every month. That's where that information comes from.
sure.
But they do have it, they just won't release it. They've
Yeah.
actually locked it and they will not release it to the public.
Yeah, to be continued in this
Yes,
story.
that's
for sure.
correct. So they are holding it hostage because they don't want that information out.
Right.
If your patient has private insurance, maybe this is a time of year where they vet their deductible. If they're willing to do a little bit of research on their own, it might be, it could be that's the discussion I'm having with a few patients I have that don't have state insurance.
It's a great idea of wait until they reach their deduct. Yeah, it's a great. Awesome. All right, thanks all. 2 more cases. Yep.
Thank you so much, Lisa.
Now I have the pleasure of introducing 2 of our next speakers. Jennifer Stewart is a nurse practitioner at the Intermountain Pediatric Cystic Fibrosis Center in Salt Lake City, Utah. She's worked in CF for over 18 years, initially as a nurse in the inpatient unit and now as the CF Center coordinator. She enjoys caring for CF patients and families. Dr. Jeffrey Zobel is an advanced clinical pharmacist and serves as a clinical support liaison for MVW Nutritionals. Dr. Zobel was involved in with the primary Children's CF Center from 2006 to 2023 by providing pharmacy services to CF patients and served as the ambulatory care preceptor for pharmacy residents. Dr. Zobel has spoken at several local, national, and international conferences on topics involved with CF and has published many peer-reviewed manuscripts in topics about CF care. Please welcome them both.
Thank you. Thank you so much. Good morning, everyone. Let me put this up. We're tall people here. Yes, I brought Jeff, my trusted pharmacist, to share some of the details in this case because it was a very complicated case. We're going to talk about treating a patient with mycobacterium abscessus, kind of going beyond the guidelines. There are no relationships to disclose related to this presentation. So we're going to talk about our patient, a 13-year-old male, heterozygous for Delta 508 mutation and a 2184 insertion A variant, CF lung disease with right middle lobe specific involvement and central bronchiectasis. He's chronically colonized with Pseudomonas aeruginosa, Stenotrophomonas, and MRSA, so a lot of bacteria. Also has asthma, moderate persistent, has intermittent control. He's pancreatic insufficient, history of gastrostomy, and is dependent on enteral feeds to maintain nutrition. He has CF sinus disease and a history of multiple sinus surgeries. Mycobacterium abscessus, which is the focus of this presentation today. Also to note, significant depression, anxiety, and a very complex social situation. So looking at his culture history, I put a bunch of cultures in there. We did have a 2018 culture where he was smear negative, culture negative. Mycobacterium abscessus first showed up on culture on August 30th of 2019 We had several cultures in between there. He was smear positive on November 12th of 2020. So we were really just paying close attention to his status and watching these cultures closely. Got a little nervous when he became smear positive there in November. This is just a picture of his imaging. CT scan in November when he was smear positive, continued with bronchiectasis, bronchial wall thickening, lots of opacities, and mild scattered atelectasis. So at that time, too, there was concern for declining pulmonary function over the past year, despite admitting him inpatient, treating the other bacteria that we know he colonizes, Pseudomonas and MRSA. He had a decreased appetite, fevers, fatigue. His FEV1 trends quickly dropped. He went from 118 back in 2018 down to 90% in October of 2020. He did have the lowest point of 73% predicted there. His BMI percentile, while we were always working to improve it, was fairly stable at the 38th percentile. So I just added in there from the guidelines, in patients who meet diagnostic criteria, we suggest initiation of treatment, especially in the context of positive AFB sputum smears and or cavitary lung disease. So we recognize with both of those things, him being smear positive on the culture, changes on CT scan, declining lung function and symptoms, that it was probably time to treat. Oops. Oh, sorry, I clicked the wrong thing. Thank you. Okay. Just to review common symptoms of NTM, which our patient had all of these intermittently. Cough, hemoptysis, night sweats, fever, that was probably most concerning to him or most annoying to him, lots of night sweats and fevers. He did end up having weight loss and didn't have much of an appetite. Decreased energy, he was not able to attend school for a lot of that year. Feeling short of breath, having intermittent wheezing, and then he did complain of some chest discomfort. So we, of course, sent all the cultures in and we got susceptibilities back. We worked with both our local ARUP laboratory and sent cultures to National Jewish for more extended sensitivities. Unfortunately, this was what we saw on his culture results. So only susceptible to linezolid. And we didn't have linezolid as a great option to treat, both because he's chronically colonized with MRSA, so we didn't want to create any resistance. He was also being treated with an SSRI, so there was a contraindication there due to the risk of serotonin syndrome. So we steered clear from linezolid. This is what we had for our other susceptibilities. We worked really closely with pharmacy, our infectious disease team, and decided to treat him. We admitted him to the hospital for initial treatment. Started with inhaled amikacin. Even though it was resistant, we decided that maybe the inhaled would give us better penetration. So started inhaled amikacin twice a day, IV cefoxitin, IV imipenem, and then azithromycin. Of course, with IV treatment, he needed central line access, so he did have a PICC port placed, which our interventional radiologists will place in our hospital. Of course, we obtain all the baseline testing, EKG, hearing, vision, all of those things. And he was in the hospital from November 30th to December 4th, just to make sure we had all the drug levels, that he was tolerating medications, and then we sent him home with close follow-up. I forgot to mention, before we started all of this, we had a serious conversation with the family regarding the intensity and duration of treatment, and we also discussed the importance of adherence during this plan. So everyone was on board. We all agreed that this was going to be the best treatment plan for him. He was only 11 at the time, but him and his family had a good discussion and were all on board with the treatment plan. However, this did include lots of visits. So after we sent him home on this treatment plan, we saw him monthly. The family does live out of state. They were in Idaho, we were in Utah. So some of our visits were virtual visits. This was also all during the time of the pandemic and lots of things going on. So we did do some of those visits virtually, which we worked really closely with our infectious disease team, and they were great to come down to clinic, jump on a virtual visit with us and the family so that we could all make sure that we were coordinating cares. We really tried to get monthly AFB cultures, sent him home with a bunch of sputum cups and had him drop them off at his local laboratory. Some difficulties there too, but we really tried to get monthly sputum samples. We generally see him in person at least every other month, so we didn't go more than 1 month virtually. He did have a home health nurse come to his home and would collect, they do the port cares monthly and get a monthly CBC, CMP. So things worked pretty well, and he was overall tolerating therapies. Decided to switch over to the continuation phase in March of 2021. So we continued his inhaled amikacin and then stopped the IV drugs and switched over to oral omadacycline, oral clofazimine, and continued the oral azithromycin. This is the plan that we decided on and what was prescribed, but I brought Jeff here to talk about the realistic logistics of this treatment plan because it wasn't as easy as it looks on this slide.
All right, so getting the medications the difficulties actually started in the hospital with his IV therapy going home, because we consulted our discharge planners and they said, oh yeah, we'll take care of it. They had almost 2 weeks to take care of it. Well, I was working from home, being virtual, and all of a sudden I get this call from the medical residents. Oh, they sent down to the local pharmacy downstairs to fill. And I'm like, you can't do that, guys. It's IV therapy. So I called the discharge planner and said, did you call the insurance? No. Well, you've had 2 weeks to do it. No. So I took it on, called our home infusion pharmacy, and they did it, and they delivered to Idaho. So that was the first thing, getting him out the door just on his medications. But then getting the oral therapy, we had a pharmacy resident who was with us, had actually done a rotation at National Jewish. And that was awesome to have someone actually seen the National Jewish process go through. So she and I developed this algorithm of how to give all these meds and timing of how to do it. Because one of the things was omadacycline. Who's ever had to use omadacycline before? What's the biggest issue with it? Cost, getting it, yeah, okay, what else? Side effects, and the number 3 is timing. Okay, the timing of this kid was on nighttime feeds that started at 8 p.m. and went till 8 a.m. Well, this kid had to get up at 3 a.m. to stop his feeds, do his treatment, because it has to be 2 hours before and 4 hours after. So he could even go to school. So that was one of the issues with the omadacycline was the timing of it. He was also 11 years old. What's it FDA approved for? What age? 18 and above. Okay, well, how do you get a drug that is $15,000 a month for a patient who is a PEDS patient? So I called and tried to get the copay assistance card. You can't, because you have to be over 18. Family had to pay $5,000 to meet their deductible. Of course, they have a copay accumulator plan on top of this, and it's March. And so they had not met their deductible, so the mom had to pay $5,000 out of pocket on her credit card to get the omadacycline. Then we had to find a pharmacy to dispense it. Who can dispense omadacycline? Walgreens specialty is one of them, and then you may have other ones can. But we had to find a Walgreens in 3 states. We had to figure out they could dispense to Idaho. They had to have an Idaho license and to be able to do it. So all the Walgreens, the only one that had it was Utah specialty, Walgreens specialty. but they had to get it from Colorado, shipped over, and then they could dispense it. So that was a lot of time and work on the phone just to get the metacycline. The cost, the $5,000 just for that original copay, but then the family was on it again. They had to do it again. They had to pay $10,000 for their omadacycline treatment. The timing with that, so he had to get up. It was not fun for the son, and we'd have to do our monthly visits, and he would say, okay, how's it going? Well, we have to get up at 3 a.m. and do this, and then we did the Clofaz and the azithromycin at night, so at least he could do this, and he had to do his amikacin, so there was a lot of stuff going on. The Clofaz was the funnest one. So actually we had an IND already in place, so that was not the hard part, getting the Clofaz, but it was getting the study drug to the family. So how do you get this drug, how do you get the Clofaz, is if you've never done it, you have to deliver it to the center. Well, so they deliver to the center, they give you a 100-day supply. That's if you're doing the standard dose. Well, we did the standard dose, got them 100-day supplies first 100 days. Well, then we tried to contact them for their next clinic visit to time it. We could not get a hold of mom. Finally, they walk in, and I said, first thing he says, how much Clofaz do you have? We have 5 days left. You get it from the National Hansen's Laboratory in Baton Rouge, and it can take up to 5 to 7 days to come. That's if everything works with your study coordinators and getting it. Well, this family lived in Idaho. So the drug came on a Thursday, and Jeff took a road trip. I drove to Idaho on a Friday afternoon, and I coordinated with him to stop at a gas station in the middle in between, and I showed up with a brown bag with my sunglasses on, and I had texted the mom, she pulled up, I handed her a bag, and I drove away. That's how this had to work with the Clofaz. So again, when you say when Sarah said yesterday, it's not an easy thing to get. Yeah, it's not anything you say. Once you get it, now you got to get it to the family. Well, we also decided, because what's the main marker, the side effect of Clofaz? You know, it's working. They look like Dave Young, right? They're tan, right? This kid looked like Charlie Brown. He was white. I mean, he had so we had to increase the dose in that 5-day time. So we actually only had 2 days. So we had to do a little bit of a ring around to get this to them. So these are the complications. That's what pharmacy did in this aspect. Working with ID just said, do it. I said, yeah, that's great. Now you got to make it work. So that's what we had to do to get this for the kid. So I'll turn it back over to Jen.
Thank you, Jeff. Thank you, Jeff. Okay, so we can't talk about treating a CF infection without talking a little bit about airway clearance. We know that that's an equally important part along with the antibiotics. So we really tried to optimize this patient's airway clearance at home. In the hospital, he does great with 4 times a day RT coaching airway clearance. In the hospital, he would benefit from Metineb or IPV. So we really wanted to try to mimic this for home. So our goal was for him to do Vest twice a day at home and the Valera twice a day at home. The Valera itself was pretty tricky to get. We worked with the company and insurance company. Family did still end up having to pay quite a bit out of pocket. It was a significant cost for them, but they felt like it was worth it. So they were able to get it, and he did benefit from using the Valera at home. It really helped him to mobilize secretions where he had a difficult time doing that with Vest alone. So we really tried to use a combination of therapies for him. We did also increase his Dornice alpha to twice a day, had him do hypertonic saline twice a day, and then really encouraged physical activity as well. So a lot on his plate, as you can see. Of course, at the time, we were all hopeful for this upcoming ETI therapy that was on the horizon for him. We suspected that it would be really beneficial. However, it was not yet approved for his age range. At the time he was 11, it was approved for 12 and up. So we applied for compassionate use, really tried to get early ETI therapy for him. Unfortunately, we were told his FEV1 was too high at the time, so that was denied. I will say in here he has twin sisters who were on ETI therapy. So a few thoughts ran through our head. But ultimately, we do not recommend he steal his sister's drug. Luckily, in July of 2021, ETI was approved down to his age range, so we were able to get him started on therapy. And that was, as we had hoped, very beneficial for him. Started in July. By August, that next follow-up visit, his FEV1 jumped to 118%. So we were all cheering, celebrating in the hallways. He was excited, really happy to see a really big improvement. And he had his first negative AFB culture in quite some time. So we were also excited about that. Unfortunately, he continued to be positive on culture, but he felt better. He noticed a significant improvement in symptoms, was tolerating the drug regimen fairly well, and noticed even more improvement once starting ETI therapy. We're also excited about his nutritional status. His BMI and appetite improved, and he continued to grow well. Once we started him on ETI therapy, we had difficulty obtaining those monthly AFB cultures. As lots of people have mentioned, he noticed less mucus on therapy. So we ended up needing, it was really hard to determine length of therapy without significant cultures. So when we'd bring him into clinic, we would have him do sputum induction. He was there for hours just trying to get sputum. We did end up doing some bronchoscopies as well, but really worked hard to try to get these cultures. You can see the trend there. He did have some negative cultures, ultimately was smear positive while he was still growing abscessus. We felt like it was suppressed enough that he was feeling well, and lung function and nutrition were both really stable. So he completed a total of 21 months of NTM treatment. It was a very difficult and intensive course, both for him and the family. As you've heard, there was significant cost, significant time. It was a pretty strict regimen. Living out of state, they had more frequent visits. It was pretty intense for them. In September, we decided he was doing well. Everything was really stable. He felt good. We decided to discontinue the treatment plan in conjunction with the infectious disease, the family, the whole team. It was a big discussion. So he stopped treatment. We sent him home, restarted the TOBI therapy just because of his chronic colonization with Pseudomonas, and continued on ETI therapy. Now, who thinks this is the end of the story? It's not. I wish that this is where we left things, but after we stopped his treatment in September, he took a hiatus from us. There was quite a gap in care, and we didn't see him back in clinic for 5 months. Unfortunately, there was a lot going on psychosocially with the family. When he came back to clinic in February of this year, his FEV1 had dropped down to 99%. Luckily, his weight was still really stable. We decided to target the chronic bacteria that he grows, and he was treated just with an oral course of doxycycline. Unfortunately, he declined, and in March, he was admitted through the emergency room with fevers, fatigue, shortness of breath. CT scan showed continued bronchiectasis and opacities. His FEV1 dropped down to 89% with that hospitalization. So we were worried that the mycobacterium abscessus was back and that we would have to restart treatment. But of course, we know this is a slow-growing bacteria. We weren't going to make any quick, rash decisions, just continue to monitor and watch him closely. So we worked with our infectious disease team, treated the MRSA and Pseudomonas. Initially, he was treated with IV ceftazidime and tobramycin and vancomycin. We were also searching for other reasons for fevers, so ruling out central line infection, consolidations, viral illnesses. Infectious disease recommended switching his IV antibiotics. So we stopped the vancomycin and switched him over to IV ceftaroline, slow infusion, and then levofloxacin and tobramycin for the Pseudomonas. And he did improve with this treatment. He also got a bronchoscopy during that hospitalization. And unfortunately, his AFB culture from the bronch was smear positive. So the cultures were sent to outside laboratories. We sent him home after a couple of weeks of being inpatient. His fevers did resolve. He improved clinically just with the standard treatment and aggressive airway clearance. His FEV1 improved from 89% on admission to 116%, so back up close to his baseline, and he felt better. So we sent him home with lots of cultures still pending and just waiting for sensitivities. He came back to clinic in May again of that year. Unfortunately, FEV1 was down again. He's had a lot of this back and forth. He was still complaining of increased fatigue, was missing a lot of school. However, with the complex treatment and his susceptibility patterns, we were not quick to jump on to treating his Mycobacterium abscessus again, especially with him being so young. We talked to him more kind of about what was going on at home. As I mentioned, a complex social situation. And he did end up telling us that he was not being real adherent to his Trikafta and not being consistent with airway clearance therapies. So we really talked to him about the importance of those things and tried to support him in other ways with our CF psychologist, social work. We really tried to see what else was going on within the family dynamic and really focused on the goal of just improving his adherence to home therapies. He was treated for an exacerbation at that time with oral antibiotics. We did ciprofloxacin, doxycycline, and then recommended he restart his Tobipod-Haler. Luckily, everything improved with improved adherence. So he came back a few weeks later. His FEV1 was back up to 119%. BMI is excellent, and this is without him needing to use gastrostomy feeds. And then he's been able to maintain that at follow-up visit as well. So he's doing so much better. We'll see him back in clinic after the conference. So hopefully he's continuing to maintain these therapies, but overall stable and feeling much better just with Trikafta and airway clearance at home. So we continue to watch his cultures, but hoping to avoid restarting NTM treatment. So takeaways from this situation: complex drug resistance patterns led to outside-the-box multi-drug treatment plans. We worked really closely with National Jewish and our local infectious disease teams and had significant communication and ideas all between us, the family, laboratory. I think we all know that NTM treatment is lengthy and really difficult for families to adhere to. ETI is more effective when taken regularly, shocker, and prescribed with fat and enzymes. And then ultimately, I think we were excited to see that ETI therapy may have a profound effect on bacterial infections for CF patients. So even though he continues to grow Mycobacterium abscessus, we hope that with ETI therapy, it won't be problematic and cause significant declines if he can maintain his current regimen and treatments at home. And added email if there are any questions, and then we'll take a few minutes for questions if anyone has any.
I just had a comment to make. I have a similar situation where we've had to do long-term abscessus treatment in a kid, and he flat out just said, I'm not taking this drug on an empty stomach for omadacycline. He's like, tube fed, not doing it. And so he continues on therapy, but we do that one IV. So he gets one IV left, and it is IV omadacycline, and he's been really successful with that. So it's just one way to help him adhere to it.
Yeah.
Thank you for sharing.
And we had thought about IV, but we thought, let's try oral, and then we realized the complexities of omadacycline itself is, and then the side effects alone. I mean, he was not fun. He had a lot of nausea and vomiting, so we had him on Zofran and other, continuous things just to kind of help control his nausea and vomiting with it.
Any more questions? All right, thank you so much, Jen and Jeff.
All right, our last speaker today is Julie Lennon. She's practicing at Nationwide Children's Hospital as a staff specialty pharmacist for the last 8 years. She worked in retail for 24 years, where she gained a vast knowledge of insurance claims and billing. She submits PAs and has become an expert and go-to person in getting medications covered in challenging situations. She enjoys her job and loves seeing improvement in her patients, and that is what keeps her from retiring. Welcome, Julie.
Good morning, and thank you for having me. So this is going to be more insurance-driven than your typical therapies and stuff. Sorry.
No, you're.
Where do I hit? Oh, okay, thank you. Oh, there's my disclosures. Okay, so my objectives are to explain the structures of various billing programs, sometimes called copay adjustment programs. I'm going to describe a precarious billing case and identify concerns related to various payment structures. So these are called copay adjustment programs. I'm going to go over and show you how the billing works with them. I'm going to go over an accumulator program, a maximizer program, and what I call a modified maximizer program. So accumulator programs are strategies used by insurance companies and pharmacy benefit managers that does not allow the copay assistance to go towards the deductible or maximum out of pocket. So these PBMs keep track exactly what the patient's paying. They don't allow other insurances. Each insurance has their own accumulator, so they report back exactly what they're paying, and they don't count the copay cards to go towards it. So here's an example of a non-accumulator plan. So the insurance is billing, the pharmacy is billing the insurance. The payer pays about $25,000 for this prescription, leaving the $7,000 copay. That pharmacy bills the copay to the copay card. The copay card picks up that $7,000 and the patient pays $0. So then the next month when the patient goes in, pharmacy bills it, the payer pays the $32,000, don't need the copay because the patient has met their deductible, so the patient has a zero copay. So February through December, this patient has met their copay, has a zero, or met their out-of-pocket and deductible and has a zero copay. So when you have an accumulator plan involved, you'll find that these manufacturer copay cards know this patient has this particular insurance, and then they adjust what they will pay per claim on that copay card. And sometimes they even adjust the total value, annual value. So, and the insurance know this. So the insurance know how much is on the copay card too. So they'll adjust the copays to what the copay card will pay. So when we have an accumulator plan, remember this is when the insurance reports back what the patient actually pays. So this, you go to the pharmacy's billing, the insurance pays the $28,500. They're left with a $3,500 copay. The pharmacy bills the $3,500 to the copay card. It picks it up, and they have a zero copay. So this happens January through May. So come June, when the pharmacy bills the insurance is only picking up the $28,500 like it has. We're getting low on funds on our copay card. So the pharmacy bills the copay card to $3,500, but now the copay card's only picking up $2,500, leaving the patient a $1,000 copay. Whoops. So then in July, we've maxed out the funding on the copay card, so the pharmacy's billing the insurance is paying the $28,500, leaving a copay of $3,500. There's no funding on the copay card, so now the patient's having to pay $3,500. Same in August, they're paying $2,500. But when they come in September, the pharmacy's billing the insurance is picking up the $32,000, leaving a zero copay. Now the patient has met his deductible, so September through December, the patient has a zero copay because he's met his deductible. But you'll find with the non-accumulator plan, the patient met his deductible in January. This patient didn't reach it till August because he has an accumulator plan. There's disadvantages for these patients that have accumulator plans. The copay does not go towards the out-of-pocket or deductible if the copay card's paying. The insurance company's benefiting because they're getting paid by the card, and the patient will still have to pay more out-of-pockets towards its medical cost. This is moving more of the healthcare cost onto the patient and away from the insurance companies. So some more copay adjustment programs are a maximizer program. And this is an approach where the maximum value of the copay card is applied evenly throughout the year. This assistance, again, does not go towards the deductible or the maximum out-of-pocket. And then what I have is this, what I call the modified maximizer programs, and these are where the maximizer program that is offered by a third-party vendor partnered with the insurance and the PBM. Some examples of this is Caremark's partnered with Prudent RX, Express Scripts partnered with Save on SP, OptumRx is partnered with OptumRx variable copay programs. And this is just a few of them. There's a lot of other ones out there. So the billing structure of just a maximizer program is, again, the insurance company knows what the value is on their annual value on this copay card. So the insurance company knows this value of this particular copay card is $84,000. They divide it over the year, making it $7,000. And then, so what happens is pharmacy bills, patient has a $7,000 copay, pharmacy bills the copay card to the manufacturer copay card, they pick it up, leaving a zero copay for the patient. And so this just happens January through December. Patient doesn't really care, they're paying zero, so sometimes they don't even realize they have these programs until they haven't met their deductible. So then what I have is this modifier maximizer program, and this is when you have this tertiary payer, I call it. And again, the variable copay, you can see it's different because the manufacturer copay card knows what insurance this patient has, so they adjust the copay. And this copay card has a maximum value per year is $20,000. So the pharmacy bills the insurance, they have a copay of $7,000. The pharmacy bills that $7,000 to the copay card. The copay card picks up the $3,500, leaving a $3,500 copay. Then that pharmacy bills this tertiary payer that $3,500, which then picks it up. So you can see January through May, the tertiary payer picked it up. Patient's still paying zero. So come June, we still have that $7,000 copay, but we're running out of funding on the copay card. So the pharmacy bills again, the $7,000 to the copay card. Copay card's only paying the $2,500 now. The pharmacy bills that $4,500 that's left over to that tertiary payer, and they pick up the $4,500, leaving the patient a zero copay. So come July through December, the patient still has that $7,000 copay. The copay card has been maxed out. So the pharmacy's billing that $7,000 to the tertiary plan, and they pick it up, that third-party vendor. So basically, the patient's still paying $0, and again, as I said, patients don't really know what's going on in the background. So there are, again, disadvantages for these patients. With the Maximizer program, the patient's still paying the same, but they have not met their deductible this way. It's just going to take them longer to get to it. The payer has the advantage of the value of the copay card, and the patient still has to reach his deductible. The patient has the advantage of the zero copay with these programs, but what happens when the funding of the copay card is deleted? Will he still be able to access or afford his medications? Luckily, in our specialty pharmacy, CF, we've not really had a problem with this, but in the other disease states in our pharmacy, I have seen where patients cannot afford their meds. Their manufacturers haven't been forthcoming. We're kind of lucky in CF that way, or our center's been pretty lucky that way. So I'm going to go to my patient case. We had a 14-year-old CF male that had two insurances. They had a primary insurance and a secondary insurance. The primary insurance being commercial, the secondary insurance was Medicaid. And we had been billing this patient's insurance about 3 months, and we were billing the copay to the Medicaid. So we get a call from this copay maximizer advocate informing us that this patient, great, they have this, they're enrolled in this plan. All you have to do is enroll this patient in a copay card. Well, we proceeded to tell that advocate that this patient does not qualify for a copay card because he's on Medicaid. You'll find that patients aren't eligible for copay cards if they're on a federally funded insurance. Example, TRICARE, Medicare. And federal employees aren't allowed to have manufactured copay card. But this patient had Medicaid. So then the advocate informed us, since the patient had Medicaid and could not get a copay card, they did not qualify for this plan. They said they're the payer of last resort. So if you remember on the last slide we went over, this is if this patient didn't have Medicaid, this is how the billing would have gone. But since this patient had Medicaid, this patient had a $7,000 copay card, or copay, not eligible for the copay card, wasn't eligible for this tertiary payer, what we were told. So they picked up none. Medicaid was picking up the $7,000 for this patient. For a year, we're talking $84,000 that Medicaid was picking up. So to continue on our case, we still ask this advocate for the billing information. I find that if you have the billing information and it goes through, adjudicate, get a paid claim, this patient's eligible. So the advocate stated again, because this patient had Medicaid, they didn't qualify for this program. Then we started asking questions. Who's paying this? Who's this tertiary plan? Is this the insurance company? Is this the employer? Who is paying this? She would not tell me. The advocate refused to disclose the billing information to us. These tertiary plans, they have these strategies we've found. There's really no cost savings to the patient. The tertiary payer is not informing these patients they have this plan. We've received calls 3 or 4 months later from these advocates asking us to rebill claims because the patient had this plan and they wanted to readjust the payments where they were going, who was picking up what. And sometimes you'll see they'll strongly urge these patients to get a copay card. And as you know, if they're federally employed or, I went over those examples before, but a lot of times we have off-label patients. And if you're off-label, again, you don't qualify for a copay card. The tertiary payer may say they're eligible for Medicaid. They're not eligible for this, which happened in our case. Also, the tertiary payer may force a patient to use up their grant money, i.e. HealthWell. We actually had a patient getting prescription at another specialty pharmacy, and they had used up this patient's HealthWell, and we got a call from them stating, hey, this patient has a $1,000 copay. Can you figure out something how to help this patient out? Well, at that time, there was no other grants open, and so we asked the specialty pharmacy, well, do they qualify for these maximizer program? Is their insurance a maximizer program? They called us back later and said yes. But after this, the patient had used up all their HealthWell, and all this time they were eligible for this tertiary payer. So, and also they want us to use Medicaid first. So our ethical billing, what we feel, is the cost of the drug is $32,000. The patient's copay is $7,000. We know there's no copay card for them. We feel that the tertiary payer should be picking up that $7,000. Patient still pays zero. So the maximizer advocate did allude that the tertiary plan was the insurance. Why is it important who this tertiary payer is? If you look at the Medicaid Gov website, if you do under coordination of benefits, they tell you, they'll list what needs to pay. They say they are the payer of last resort, and all the other funding needs to be paid, excuse me, before you send it to Medicaid. So what ethical challenges presented here in regards to who's paying? Does anyone? Do you legally think the pharmacy should pay for the pharmacy? Do you legally think the pharmacy should bill Medicaid? No. Well, are the pharmacies being compliant with their Medicaid contracts when they're doing this? I'm sure we're not the only pharmacy that was doing it. I can do another short story that just happened. This was like a year or 2 years ago. So we, about a month ago, we got a call from an advocate asking us to, the first question they asked is, does this patient have Medicaid? And we said yes. And they said, well, we need you to back out your Medicaid billing and bill, or wait, you need to back out your tertiary payer and bill Medicaid. So what we figured out what the billing is, so, these tertiary payers won't tell us what the billing is, but we know, a year later, we know how to do it. And so we had been billing the tertiary payers. And they were very strongly pushing us to back out the claim. So we said, well, we need to talk to, you need to talk to our supervisor about that. So they had routed it up on this tertiary payer, and finally they called back and they spoke to our supervisor. And my supervisor came to them, said to them, we feel that it's unethical and illegal for us to be billing this Medicaid when we have you that we can bill this to. And the rep that came back said, well, we feel that it's not illegal. And my supervisor said, well, it's not our pharmacy's policy to do this. And the rep goes, well, if you feel it's not your policy to do this, then we won't be calling you anymore and you can bill us. So that's how that ends. So our pharmacy is billing the tertiary payer. We are not billing Medicaid, but anyway.
So they try not to pay?
Oh, yeah, yeah. There's all kinds of financial reasons why they're doing that, because they make money on they make money for the insurance that's contracted with them. I think they get like 25% of what that person saves. It's different, I don't know. It's all about money. But any questions or?
Well, just most insurance subscribers, I have no idea if I have a tertiary plan or not, correct?
That's correct. Most patients don't know And then when they think they've met their deductible, they haven't really met their deductible because none of that stuff you're paying. I've also seen where a lot of insurance will not have specialty pharmacies go towards their deductible, no matter whether they're paying or not. And most people don't know, most patients don't know about their insurance. So, and I want to thank Emily. I wouldn't be here if it wasn't for Emily. Oh, gosh, come on. I just had a terrible problem. Okay, thanks. All right, here's my references. Any questions or concerns or?
How high up in the line at this tertiary payer did you have to get before somebody could have a conversation with you? Because I found that when we call, no one seems to know anything about what's going on or how their own program works. So how did you get to somebody that you could have a conversation with? I'm assuming they had to put some sort of override or something in to let the tertiary payer.
No, there's no override. And that's why I said, that's why I asked for the billing information, because the claims go right through. Now, there's other plans that they're a little more structured, but with this one, if you have the billing information, it'll go right through. And so.
It must be hard to actually get to the right person.
Yeah, sometimes you have to be forceful. You don't take no for an answer, I've learned. You just go up the line. Okay.
Any more
Thank you.
questions? All right, thank you so much, Julie.